Good evening, everyone. Hello, my name's David Lockey. I'm chairman of the Faculty of Pre-Hospital Care. I'd like to thank the president of the college and the college for dedicating one of its very popular webinar slots to the Faculty of Pre-Hospital Care. The Royal College of Surgeons of Edinburgh is a broad-minded organisation which recognises surgical disease in all its forms. And it's fairly unique because of that in having a number of faculties which is supported for many years, which is what we are, and we've been a faculty of the college for considerably more than 20 years now. We represent pre-hospital care providers from all backgrounds and deliver education, standard setting and examinations in pre-hospital care and in the new subspecialty of pre-hospital emergency medicine. This is the first webinar presented by the Faculty of Pre-Hospital Care. This evening, we've concentrated on the early management of trauma, which we hope will appeal to a wide range of college members. We've got three excellent speakers, a neurosurgeon and two emergency physicians, who interestingly, despite their different career paths, all hold surgical fellowships. The presenters are experienced trauma experts from different centres and different backgrounds who've made major contributions to their areas of expertise, but also trauma and pre-hospital care more generally. This series is about COVID, but we recognise the fact that you may have been slightly overexposed to that, and we will bring elements of COVID into tonight's webinar. But we're actually going to be talking about the early management of trauma. So first up is Mark Wilson. Mark is a consultant neurosurgeon at St Mary's Hospital in London with an interest in head injury. He's a pre-hospital care doctor who's worked on several UK air ambulances. As well as a chair at Imperial, he holds the Gibson Chair of Pre-Hospital Care at the Faculty of Pre-Hospital Care. And he also co-founded the extremely successful Good Sam app, which we'll hear a little bit more about later. So Mark's going to talk to us about the early management of head injury and spinal injury. Mark, off you go.
Thank you, David. Now, you can hear me okay? I'm just going to share my screen, if that's all right, which should bring up some slides. We've got 10 minutes to cover quite a large topic, and I'm not known for speaking slowly at the best of times. So I apologize for this, but I'm going to talk mostly about brain injury and then a little bit about spine. And then hopefully you can ask some questions at the end. I haven't focused on COVID here at all because, to be fair, most of the principles don't really change with COVID other than the PPE you might be wearing. So firstly, I've got a little disclosure to make that I am a co-founder and medical director of Good Sam, as Professor Lockey mentioned there. Very briefly, all head injury management can really be divided up into management of secondary brain injury. Primary brain injury is what happens when your head hits the windscreen, and secondary brain injury is everything that happens after that. And our job as clinicians and as scientists is to minimize that secondary brain injury, whether it be hypoxia, hypertension, or the involvement of the clot. And those concepts of secondary brain injury have really been evolving over the last 50 years or so now. So initially by Miller, then Randy Chestnut really put that forward in the 90s. But there's been many papers that have shown that hypoxia and hypotension do you harm. So if we start with hypoxia, everyone's probably now heard of the concept of impact brain apnea, this phenomenon when your head hits a windscreen, you stop breathing, a phenomenon that is well known in the animal world, that if an animal is hit on the head, it stops breathing, has a period of apnea. If you resuscitate the animal, then it will start to breathe again eventually, but if you don't resuscitate it, then the animal dies. And there's also a bit of a claiming surge in that as well. It doesn't matter what animal you take, the harder you hit them, the longer they stop breathing for. A concept, as I say, called impact brain apnea, and seems to be very well associated with some code red patients. So about 15% of patients that come in who are hypotensive are found to have just an isolated brain injury. So although we're taught in ATLS that shouldn't really be possible, you shouldn't be able to bleed into your head enough, but actually there is some kind of autonomic reaction that occurs that makes people hypotensive as well. And this is how we sadly commonly see it. This is people who have had a hypoxic brain injury, usually because of apnea or loss of airway. And I would argue that we really need to classify our diseases very well at the start to learn how we can minimize them. Because this person hasn't got a devastating brain injury. There's not lots of blood in their head. They die because they've had because they've had an apneic period. So moving on to pre-hospital intubation, trying to sort out apnea. If you go back 20 years, intubation was seen as a bad thing in the pre-hospital environment because it wasn't really done properly. There were lots of places that were having a go, and that was gave pre-hospital intubation a bad name. But certainly in Australia, and the work that's been done by London's Air Ambulance, by Professor Lockey and others, has shown that in well-governed environments, pre-hospital intubation is a safe thing to do. Now the question is really around how should we be optimizing that even further? Should we be using video laryngoscopy routinely? Does it make things quicker, safer? And other aspects, the logistical elements of airway management. And, the nice guidelines are that you should be able to have be intubated within 45 minutes of your injury. And that's possible in places where you've got an advanced ambulance service and the density enables it, but it's not possible for most of the country. Blood pressure is next sort of secondary injury. There's been good evidence now that shows that hypotension is bad for your head injury. And literally by about every 10 points decrease in blood pressure, your odds ratio of death can increase by about 20%. But I would argue that not all brain injury is the same. Like not all cancers are the same and different treatments are there for different cancers. Brain injuries consist of different types of injury as well. And it might be that when we start to dive deeper into these types of brain injuries, we'll find out that some are managed with more optimal blood pressures than other. But because we don't know on seeing what we're doing or what we're doing in terms of what injury the patient's got, we don't necessarily titrate the patient clinically to exactly what might be appropriate. End-tidal CO2, we all know that now that a normal end-tidal CO2 is what you should be aiming for in patients that are ventilated. And that was really by Jonathan Coles' work from Cambridge in 2007, which showed that hyperventilating people actually reduce brain oxygenation. Cooling patients, lots of enthusiasm for cooling over the years. Eurotherm showed that was bad on intensive care, and Polar has shown that that's probably not a great thing for pre-hospital care either. It didn't really improve, didn't make things any worse either. But always look at how these studies are done. Polar was mostly around giving people a large volume of cold fluid, and what you might be looking at there is the effects of a large volume of cold fluid rather than the effects of cooling. So you've got to interpret these studies with a little bit of caution. Agitation, I appreciate I'm going to have to now change my slide to someone else, but agitation I find one of the most difficult things to manage in the pre-hospital environment. There are so many different causes, from head injury that they've just been in a fight, they might be carrying on the fight, to drugs and alcohol, pain, fear, hypoxia, impact brain, we just said. All these different things can contribute to agitation, and managing that is really hard and may end up being intubating the patient as it is. Next sort of topic was anti-Cragging Reversal. Again, big change in this over the last sort of 15 years or so, very much led by Anne when she introduced Oxplex and Beriplex on London's Air Ambulance, being able to reverse people on warfarin. Now that was at the time was revolutionary, but it's actually now quite old. The problem we have now is the NOACs and the DOACs, and trying to reverse those. Far more difficult to do that, certainly in the pre-hospital and even in the in-hospital environment. But the patients that I see commonly are this sort of patient who has a small contusion on his head, who about a few hours later goes from this to this. And I talked about secondary brain injury, and our job was to minimize secondary brain injury. Well, we had an opportunity there where maybe we could have intervened or somehow stopped that from progressing to an injury where this man will never go home on his own. And I think it's worse. Well, it's definitely worse than by the people who are on antiplatelet, anticoagulant type agents. And it's a high number of the patients we see now. Nearly 40% of the patients we see are on some kind of blood thinning kind of treatment. Now, one of the studies that has impacted on this is CRASH-3, the use of tranexamic acid, which shows that in mild to moderate head injuries, you can reduce head injury-related death by giving TXA early. And there's lots of really amazing things about the studies, including the big numbers. There's lots of things that are a bit controversial about this study as well. Looking at head injury-related death, that's a difficult thing to define, and drugs that treat that. Again, you can give arsenic to people and then they don't die of their head injury-related death. That's fantastic, but it's not great for the patient. So it doesn't mean necessarily that the treatment is working as how we think it is. And there's been other studies that now sort of go against CRASH-3. But overall, for these patients that are probably on aspirin or clopidogrel or something similar, it's probably not a bad thing to be doing. Intracranial pressure is my next topic, and with it, if we're talking at the Faculty of Pre-Hospital Care in Edinburgh, the thing you have to mention is Monroe and Kelly and the people that followed them from Edinburgh that really looked at the things we know about, the things we classically take as intracranial pressure now, the sort of the static model where your brain, where your skull's a closed box, and if you put something in, you have to push something else out in compensation. And that's a great static model for extradurals and things like that, but it's a much more dynamic system than that. If you're hypoxic, you massively increase your cerebral blood flow and you can't drain blood quick enough, and your blood pressure will go up. And this is the way I kind of think about intracranial pressure, things that go on inside your head, things that go on inside your neck to reduce your venous outflow, and chest kind of problems if you're hypoxic or if you've got increased intrathoracic pressures and can't drain enough. All these things affect your intracranial pressure. It's a very much more holistic thing. Even your abdominal pressure. So if someone puts the oxygen cylinder on your abdomen, again, that will increase your intracranial pressure. Other things to try and reduce ICP, osmotic diuretics. Well, there's lots of debate about hypertonic saline versus mannitol. No one really knows which is the best. And there's going to be there's a study that's starting now run by Gavin Perkins looking into this, and something you might be able to want to be involved with if your intensive care looks at that. Now, very briefly in the last few seconds, a bit about future head injury management side of stuff. In the pre-hospital world, I think there's going to be two main things. Well, we're already starting now, is imaging is a way to look at what kind of injury people have inside the head, and biomarkers to see if they've got an injury or not. And biomarkers are released from either astrocytes or the glial cells around them. And there's a whole plethora of them with different time frames, which are important. We obviously want them to be early risers if we're going to find them in the pre-hospital environment. And certainly microRNAs and purines are things that do that. There's tools out there for looking inside people's heads, like Infrascanner, which the faculty's going to be undertaking another study with across the ambulances across the UK, which give you a good idea of where a lesion might be. But the sensitivity and specificity has to be really high up to make critical decisions about it. And there's mobile CTs, which are used for stroke, but currently not really for TBI yet. And the very last thing is about future diagnostics here, future dispatch rather, and this is the Good Sound project, which Professor Lockey's already mentioned. It's moved into being able to do video triage in the remote environments as well. And I think this is quite an important way, especially for head injuries, where it's often difficult to get the what's going on from the 999 or equivalent caller, what's going on. We want to try and find out whether you need to send an advanced crew to that patient, and the ability to assess the scene, as in like the mechanism of injury and the patient, go hand in hand with that. So if someone says, my husband's fallen down the stairs, if you can see that he's elderly, that he's you can maybe be able to get a GCS from him, for example, his land on marble floor. Again, that will determine whether you need to go and protect his airway quickly or not. And similarly, we're now using this for stroke as well, and other medical causes, lots of medical causes now as well. And there's quite a few air ambulances using this to guide them in terms of what they're going to deploy. So London's Air Ambulance, for example, uses quite regularly to either confirm dispatch from an aircraft or get it away quicker because you can make an instant decision, or preserve the resource for when it's really needed. And it makes a difference in about a third, well, 30 to 40% of cases. And it's the same whatever you look at, whether you look at 999 or 111, it always sort of varies things by that sort of amount. And the very last thing I'm going to say is that this means that we can provide care before we get there. So if we go right back to the beginning when I talked about hypoxic brain injury, if you can see someone's face down in the mud, then you can guide the person who's dialed the 999 call to go and roll the person over or put them into recovery position and clear their airway, and hopefully minimize that very early secondary brain injury. So that was a really quick run through, and I hope that wasn't much more than 10 minutes, but there we go. Hopefully that's useful for you.
Thank you, Mark. That's excellent. You've managed, for those of you who want to replay that, you've had a 30-minute head injury lecture in a 10-minute webinar, which is very Mark Wilson, which is excellent. So there are a few questions that we've got, and I'll ask you some of them now, Mark. The first one is neck immobilization is controversial at the moment, and some pre-hospital services have dispensed with hard cervical collars. What's your opinion on that?
Okay, so this is a quite big controversial subject. There is a drive, which I kind of totally get, and I'm sort of supportive of from a pre-hospital point of view, of movement away from triple immobilization because of all the things that we see as problems of that. We see the aspiration, the pressure sores, the raised ICPs, and all those things that we see for a huge number of people that don't actually even have a neck injury. What we don't see so much as pre-hospital care clinicians is the person who had a progressive spinal injury. Now, some spinal injuries progress anyway, like they've got central cord contusion, and like a bruise, it gets worse. So that kind of gets worse. The problem we have is that there's a huge medical legal sort of population around this, which, and spinal injuries is extremely expensive from that perspective. And the patients who have spinal injuries, because I've had to do a lot of this sort of research now for the study that we're wanting to do in terms of PPI kind of patient engagement, and their attitude is, well, I get better from a chest infection, I get better from pressure sores, I'm never going to get better from my spinal injury. So the currency of spinal injury to other complications from being spinally immobilized don't quite relate to each other. So whilst I am really enthusiastic and trying to drive away from sort of triple immobilization, I think we need to evidence it so that we don't necessarily get the medical legal problems as a result. That's my very quick answer to that one.
Great, thanks. Another one I've got for you. How can we influence the time to theatre in the small number of patients that need an emergency craniotomy?
When you say we influence, who's the we? But I guess that might mean everyone apart from neurosurgeons. I think it's about having slick logistics around it. So, slick pre-hospital care services that bring people straight into the right place, and then having patients having slick processes in hospital, so it's faster CT, and having theatres ready, and all that has to be done in a way that people really understand the urgency. I think one of the problems you have with brain injury is that it doesn't look that bad. I mean, often people just got a bruise on the head, whereas when people's arms are hanging off or they've got a stab in the abdomen, everyone goes, "Oh my gosh, that's an emergency." Whereas brain injury doesn't necessarily look like they've just got might have a pupil that's a bit bigger. So it's our job for those who understand to also make sure that everyone in the room appreciates the urgency for this.
And some services have a pre-alert for head injuries, don't they?
Yeah, Co-Black or something similar. Yeah, and that's a good way of getting everyone in that mindset that this is a proper emergency, not it's someone who we've got 4 hours to do a craniotomy on, because a study in the 1980s showed that if you had an operation within 4 hours, you did better than the one after 4 hours. That doesn't mean it's a 4-hour cutoff. The quicker you get to theatre, the less neurons will die.
Which brings me on to another one of your favourite topics, which is that patients with fixed dilated pupils are often turned down from other hospitals by neurosurgical centres, even if they've just blown their pupils. Is that always appropriate?
Very briefly, we did a meta-analysis of this, or Hanny Marcus and John Scott did this about 6-7 years ago now, where we wrote to the publications. We reduced down to about 5-6 publications where they'd reported on the futility of operating on people with fixed dilated pupils, and then asked them to break down the underlying pathology of the cause of those fixed dilated pupils. And actually, people who had extradurals did very well. Over 50% actually had a good outcome. Subdurals had a poor outcome. And their average time to operation was about 4 hours. So I think you've got to look at the reasons why pupils might be dilated. Firstly, they can have seizures, and that can dilate people's pupils. They can have ocular trauma. Lots of other things can occur rather than just coning. But even if you have got pressure on your oculomotor nerves from brain shift, if it's extradural, that a lot of that pressure is kept away from the brain to a degree. So I don't think it's futile. But you put it all in context with the patient in front of you, with all their history, the fact they're, if they've got liver failure and they're anticoagulated and various other things, then it might be a hiding to nothing. But oftentimes it's worth considering it. Yeah, I do. Okay.
Moving to COVID for a second. I know it's not something you've been talking about so far, but you are the co-founder of the Good Sam app. And can you summarize what it is, really briefly, but also talk about the effect that COVID has had on bystander CPR and resuscitation in general?
Okay, so in 30 seconds of Good Sam. So Good Sam is a system which originally set up about 5 years ago to alert people to cardiac arrests. Actually, was originally set up to alert people to impact brain apnea, but has a much bigger role in cardiac arrest. And it's being used in lots of places now across New Zealand, parts of Australia, and here in the UK, so that people go and support someone's airway and do CPR whilst what's going on. Now, that has a unique ability to link people who can provide care to people who are in need, geolocating them, matching them up. So NHS England came to us in about March time and said, we would like to use the platform to deploy volunteers, 750,000 people, to go and help their near neighbours who are self-isolating with COVID, or because of COVID rather. And so we got asked to sort of recruit, and we did that in 2 days. And now we deploy many thousands of people every day to go and get pharmacies or deliver food or do check-in and chat calls and various other functions. And as we go into the new wave now, it's also recruiting people for vaccine deployment and various other things as well. So it's the ability to geolocate people in need and people who need help and connect the two together. It's been pretty big in that. And the other big thing that Goodsense is doing as well is in the 999 and 111 services now is that video kind of stuff. And just so we all go, just you understand where that comes from, this all goes back to that very first thing about minimizing hypoxic brain injury, whether it be from cardiac arrest or brain injury. It's about getting someone who can use basic skills on the scene quickly and do things through your eyes, through the hands of other people, if you see what I mean. As a dispatcher, you're guiding other people to help that person.
Brilliant. Okay, just very quick one to finish. A question from one of the participants, which is that what are your current inclusion criteria for head injuries giving TXA?
So it very much follows the Crash 3 guidelines. So those with mild to moderate injury, but actually, to be fair, it's probably pretty much everyone that gets it now in most services, because it's easier to just do it and not think about it afterwards. But you had the point is giving it early more than anything else. It's important. Brilliant,
Mark. That's absolutely excellent. Because of time, we might come back to it at the end, but we're going to move on now. Our second speaker is Dan Ellis. He's looking slightly miserable because it's 5 o'clock in the morning in Adelaide and he's just got up. Dan is currently the Director of Trauma at the Royal Adelaide Hospital and co-chair of the statewide South Australian Trauma Service. He was previously Clinical Director of MedStar, which is the Emergency Medical Retrieval Service in South Australia. He's an accredited specialist in emergency medicine, intensive care and pre-hospital and retrieval medicine. And he's going to talk to us a little bit about high-performing trauma systems. Dan, thank you for joining us.
Morning, everyone. I trust that you can hear me and see my screen. Thanks for the introduction, Dave, and thanks very much, Mark, for that wonderful talk before me. Look, it's true what Dave says. It is 6 o'clock in the morning and I'm in Adelaide. I've just got to try and make sure my slides change. There we go. And this, in case you didn't realise, is Adelaide with the Adelaide Oval and the hospital there in the corner, which is the new Royal Adelaide Hospital. I just thought I'd set the scene for you there a little bit because this is the area in which we live, which is the bottom tip of Australia. And it is 1 million square kilometres. There are only 1.6 million people in that 1 million square kilometres, and most of them live under that red dot, pretty much in Adelaide and the close environs. And just again, for those of you who want a bit of scope, that's the whole of Australia and the whole of Europe fitting comfortably therein. So you can see the area in which we live down at the bottom there near Adelaide is able to cope with a couple of the geographical sizes of the UK therein. So what does this mean for trying to run a trauma system there? Well, this is the annual report of the Australasian Trauma Registry, which only just came out actually. So this is real hot off the press data from the last financial year, which was 18 to 19, and you can see all the states are all indicated by a letter of the alphabet down the bottom there. But what you can really see there, the key is the median line there of an hour to 28 minutes, and this is time from scene to the emergency department. So this is not 5 minutes load and go. This is not turning up at the door 10 minutes after you've been hit. These are patients with a median time of well over an hour. So we need a system that's going to cater for that. And our system is broad in that we have lots of assets available for us to try and get this to try and get the show on the road nice and early. But we have to accept that any trauma system or any functioning trauma system that we have is pretty much the same as everybody else's in the world, but we have to cater a lot more. Perhaps the trauma hospital can be a little bit smaller focus because we have to focus on getting these patients to the trauma hospital alive which can be a bit of a massive undertaking. So in order to do that, we need all of these elements in our system, including expensive options such as aviation and extensive communication systems. But we also need good pre-hospital and retrieval services, and that really forms a core and integral part of our trauma system. So back to the lovely aspects of Australia, and what I think I'll try and do is give you a quick case to run through so you can see some of the issues that we face. There are some lovely areas in South Australia, and you can go and spend time swimming with dolphins and swimming with porpoises and all sorts of pleasant animals. But you also find that there are sharks that will be nosing around there. And shark attack, whilst relatively uncommon, in this instance is a good example of the problems that we face. And these are the real shots of a surfer who was attacked by a shark, had his leg bitten off, and also had some injuries to his pelvis and torso area, as you can see in the picture on the right. Now, where did this happen? Very beautiful, up in a place called Port Lincoln. As you can see, really nice. Enough humans there, lots of fun. Problem is that's where Port Lincoln is. Although it looks like it's, as the crow flies, it's relatively straightforward. Even that is an hour and 15 minutes in a helicopter, or 40 minutes in a fixed wing, or if you need to go the circuitous route, then it's going to be 7 hours by road. So this is not a close place. And this is something that a chap with those sorts of injuries, who was already reported as having had a brief cardiac arrest, we're going to have a lot of problems trying to pick him up, trying to save his life. So what is the anatomy of a system that has to function in such an environment? Well, if you break it down into the core requirements, which I would say are time, communications, the interventions, and the reception when you finally get to the trauma centre, then I think those are probably the 4 points to start on. Overlapping all of those 4 points are these cross-cutting themes of attention to detail and the aggregation of marginal gains, which I'll touch upon a little bit later. So what about time? Well, time only really works in your favour if you're parallel processing in this sort of environment. So you need to spend time preparing, making sure that your team is going to arrive to an alive patient. So obviously there's no point sending a team on an hour and a half helicopter ride whilst other things are going on elsewhere in the state for a patient that's not going to survive. And you need to utilise your journey time. So the team can utilise the journey time, you can utilise the journey time. You also need to start the preparation at the trauma centre. Now, this should be a sort of a dream ticket for the trauma centre, shouldn't it? Because you've literally got buckets of time. We can phone them in the morning when this incident has happened and say to them, look, we've got somebody who's been, a complex polytrauma, and we're not going to be with you for 4 hours or maybe even more. And that should actually be a dream ticket for this for the trauma centre. But let's hold that thought, because although we do have plenty of time and the trauma centre had better be ready, there are some downsides to having those sorts of timelines. And above all, from a time perspective, you've got to keep moving. Cannot actually lose sight of the end agenda. Apologies. So communications is the next topic. And these systems like this for complex polytrauma, particularly in areas that can be remote, is entirely dependent, really, I would say, on decent clinical coordination. And the concept of clinical coordination is physician-led, a team of nurses and doctors who actually are completely separate to the retrieval team that's going to go out and completely separate to the receiving hospital. They're actually just running the whole state from a critical care and pre-hospital retrieval environment. And they have at their disposal a whole battery of tools to help them get this right, one of which is telemedicine. And telemedicine is something that really tries to take the edge off this concept of the tyranny of distance. But it also has its massive drawbacks, as you can imagine. It's a system where you are driving remotely. And sometimes some of my colleagues who work in this environment with me talk about, this is sort of like a front row in some sort of horrific snuff movie that you're sometimes watching that unfolds in front of you. And there's not much you can do apart from watch and say, I think there's blood dripping off the trolley onto the floor there. Has anybody seen that? So it's fairly psychologically challenging as well, because at the end of the day, you're just trying to buy time. And this is no criticism of the resources that are trying their hardest to save a life. These are remote clinics with people who don't see complex polytrauma frequently. So you're really trying to do the level best that you can. And then, of course, there is this concept of too much communication. And I just mentioned that briefly because that's what happens when you end up with driving people mad with this information. So the trauma centres, you're phoning them up saying, this person's got a bit worse. And they're like, well, are they here yet? No, they're not. They're still another hour away. And I'm just letting you know they're on their X unit of blood. So all of these things, you can really sort of, if you get your communications and your clinical coordination wrong, you can make a bit of a dog's breakfast of it. So it brings us to interventions. And I guess the team that you're sending need to know what they've got in their kit. You need to know what extra can you take. And you also need to have this concept of, shall I just go and get the ball rolling, or shall I delay to take the right stuff? And a classic for this is non-trauma, when you're deciding whether you're going to take anti-venom or not. But then at the end of the day, you have to stop at the hospital to pick that up. That's going to take extra time. So we can divide those, what you're going to try and take extra as kit and consumables, but also personnel. And it's very rare that we actually take extra people to scene. We just take the retrieval team now. Used to be a phase of taking surgeons or brain surgeons to the scene, but actually it just adds time and adds delay. So obviously tourniquet is something you're going to know and carry in your own kit, nice and easy. Ultrasounds, bedside ultrasounds, we carry them as well. These are all useful tools and pretty much essential to the pre-hospital and retrieval team. Blood is a bit more complicated. And I know Anne's going to talk about this in some detail after, but we take red cells and it's complicated. Only last week we lost 6 units of red cells due to temperature deviation due to a faulty thermometer. But when you're taking blood for 6-hour trips and packing it in ice, then this can be complicated. We don't take product routinely, but it's another one of those ones where you can send a licensed sirens ambulance to the blood bank and pick up some product if you think that's going to add value to the concept of getting there in a timely fashion, getting the patient back, and depending on what you could take to need. You also need to take blood warmers, obviously, if you're going to use this sort of product. So there is an option to take, but it adds time and you need to weigh that up. Fibrinogen concentrate is something that might change the balance there, and we've recently acquired this at MedStar and at the Royal Adelaide as something that we can use and perhaps take to incidents such as this. So then there's whole other concepts. Would you take a Reboa to something like this? Should you take a Reboa to something like this? And Reboa was going great guns in Australia back before COVID. This editorial that I wrote for the Emergency Medicine Australasia, but it all sort of fell in a bit of a hole with COVID, and we're not really doing much at the moment. But conceptually, would this help in this situation? You've got to say to yourself, well, if I did take it with me, would I actually just prepare to put it in, or would I actually deploy it? If I deployed it, how long would I leave it inflated? Is this a classic case where I should be using partial Reboa, or should I use intermittent Reboa? How am I going to cater for this when I've got an hour and 15 minutes, not including transfers, in a helicopter? Is it actually useful at all? You'd have to ask. Which brings us finally onto reception. Remember that concept of plenty of time and better be ready? Well, the reality is the trauma centres often have a lot of false alarms with stuff like this. So getting ready is something that is often done at the end. If you're actually going to stop the hospital to get a full trauma team, then you're going to need to be sure that this is actually what they need, rather than delaying other cases. And remember, we don't actually know what the pathology is. So we've got no CT scan, probably only ultrasound, and brings the concept of who should actually be down there, who should be standing waiting for this patient. And just some of the stuff we do on reception here. This is the new Royal Adelaide. We managed to get Rotems very early on. That Rotem machine lives in the Royal Adelaide Hospital, which allows us literally 5 minutes after the patient arrives to get a FibTem A5 and consider our options in terms of further ongoing transfusion. And we know at the Royal Adelaide alone that that access to early Rotem within the first couple of minutes of the patient arriving has influenced our spend and our quantities of blood and blood products that we've used in that time window. We've also got physically available in the emergency department blood. So there is a blood fridge in the emergency department which we can access, as well as I've said already, fibrinogen concentrate. And also, if you're going to be doing this system perspective, you've got to be really slick. You've got to really make sure that your system works well. One of the things that the Australian Trauma Registry looks at now is time to head computed CT. You can see there, although there's a median of 45 minutes, I can sort of break the confidentiality here and tell you that South Australia is state number E there. We are the fastest state in Australia to get to head CT, and that also includes the other centres that aren't the Royal Adelaide. Our median time to CT is actually 30 minutes. And this has got, when you've spent 4 hours getting the patient to hospital, every minute counts, which brings me to my final point, which is this concept of attention to detail and the aggregation of marginal gains. Because these are the things whereby if you can actually get to the CT scanner 20 minutes earlier, despite the fact that you've had a 4-hour trip over, this is where you're going to be getting those marginal gains, and that level of attention to detail is what's actually going to save your patient. So I'll just finish now. That's the end of the trauma side of things, but I was asked to cover 2 separate questions on COVID, so I will very briefly. How has COVID affected our practice, and how have you managed your practice in the COVID period? Well, this is from late last week, the Johns Hopkins slide, which I'm sure you're all used to looking at. And out of 60 million cases, we've had a whopping 27,000. And if you look at the map of Australia there, there's very few red dots anywhere, and we've had 907 deaths. So how has it affected our practice? Well, not a lot. However, we have had to prepare just the same as all of you have. And we've got a special trauma call-out criteria. Paradoxically, it makes us slightly more obsessive to keep COVID out now that we don't have it endemic. And this sort of thing helps us. So we've really cut down numbers in trauma teams and had a whole sort of choreographed dance to the CT scanner with people in adequate PPE. So it's an action card. So we've really sort of taken it to town, so much so that the College of Emergency Medicine, although we've sort of pinched a lot of it from you guys and those that have had a lot of trauma, the College of Emergency Medicine has used the Royal Adelaide Hospital COVID trauma call-out setup as its example on its website. So I'm going to wrap it up there, and apologies for going a couple of minutes over.
Thanks, Dan. That's great. I mean, I think what we often talk about timelines in terms of rural areas of the UK, and I think you put it into perspective in Australia when some of the retrievals that you do are from thousands of miles away. So, in terms of time, how important or what proportion of patients are really time critical in your trauma pathways?
Well, unfortunately, there's this whole concept of the trial of life, Dave, which is something that unfortunately, if now that patient, as I said, had a brief, was reported to have had a brief cardiac arrest up in Port Lincoln. Usually, that's the sort of one where the trial of life has failed, and if you're still 2 hours from there and they're still 4 hours from the trauma centre, that in actual fact this isn't going to be a win. So we do have that, I guess, that benefit whereby, unlike the sort of London system, where you can be with somebody in a few minutes and hopefully get them to the trauma centre within, say, 30 minutes, you're going to catch a whole different cohort of patient to what we catch. But conceptually, we have the same trauma mix. We have very little penetrating, mostly blunt, and the ones that are going to make it tend to have that brief trial of life. And our job is to try and just stretch that out as long as we can.
I think that's really interesting. So when you've got huge timelines like this, do pre-alerts for things like major hemorrhage or head injury actually make a difference?
Yeah, well, I think they do. And again, there's sort of different levels of pre-alert for us, especially for major hemorrhage. As I said, we can actually have a system whereby we can go and pick up a specially prepared massive transfusion pack from the blood people, which is properly packed and will last for the several hours, even if it doesn't get used. And we can run and pick that up. But as I said, that's going to be a 15-minute lights and sirens ride to the hospital, another 15 minutes back to the airport, or land on the roof and all the logistics of picking it up. Now, we found that whilst we've had access to that tends to work better for the retrieval market, where there's not other stuff going on. So somebody having a PPH or somebody bleeding out, you might say, well, look, I'm going to take a fixed wing. We're not lifting off for another half an hour. I'll go and get the blood and blood products. then we'll meet you on the tarmac, then we'll fly off. That tends to be the value add. For trauma, have to be honest, there's usually so much going on in trauma that it's not worth it to say, oh, well, you know, we got to the patient with all these blood and blood products, but their airway occlusion or their head injury and our failure to ventilate them early meant that they actually died anyway. So it's a real nightmarish balance. But what we do have on the flip side is plenty of time to warn the hospital to say, look, you know, we're on our 5th unit of blood, even for the short jobs. You know, we're bringing somebody in, he's had 4 units of blood in the back of the helicopter, we'll be on the roof in 10 minutes, get a massive transfusion pack and get that ready. So it allows us preparation time at the hospitals in a lot more detail, those pre-alerts, and allows us to consider the options when we're clinically coordinating. Brilliant.
Thanks, Dan. There's a few questions for you which you might want to answer on the Q&A thing. So let's move on now. Our last speaker is Anne Weaver. Anne is a consultant in emergency and pre-hospital emergency medicine in London. She's the major trauma director at the Royal London Hospital and former clinical lead at London's Air Ambulance. She's been a leader in the introduction of blood and blood products into UK pre-hospital practice, and she's going to talk to us about the subject, which is extremely topical, of early transfusion in trauma. Anne.
Hi, David. Thank you very much for the introduction. Right, thanks to my previous speakers and friends as well. So what I'd like you all to do is, I'm not sure of the age range of the people in the audience, but I'd like you to take yourself back to 2008. If you're a student, think about what it might have been like to work in trauma in 2008. And let's just remember that in the UK, we had no national trauma system. We had massive transfusion packs, not massive hemorrhage protocols. Most emergency departments didn't have blood in their resuscitation room. Standard pre-hospital resuscitation for exsanguinating patients was normal saline, and no air ambulances in the UK carried any blood products at all. If you were lucky, you might request it via a flying squad and the police would go and get it from the local hospital. So fortunately, we're in a very different place today. What I'd like to spend the next 10 minutes doing is really just probably tell you a bit of a story about how we've tried to innovate, not just in London, but across the UK, to try and improve the delivery of blood products for patients in the pre-hospital environment. Okay, so having tested this, I can't move the slides.
If you just click once, Anne, onto the slides, you'll be able to move them forward.
Okay, thanks. Thanks, Ryan. Okay, so for those of you who aren't pre-hospital practitioners, to give you a bit of insight to the UK situation, there's 39 aircraft across the UK operated by 21 air ambulance charities, and they, on average, attend about 70 patients a day who have either critical illness or critical injury. And the interesting thing about this is, while some have some NHS funding, the majority of the £60 million it takes to run these organisations is provided by charities, thanks to donations from individuals, companies, corporate organisations and communities. When you think about blood products, you probably think about packed cells, platelets, cryo, FFP and fibrinogen. And there's been multiple papers in the literature over the last decade, all trying to demonstrate whether these products make a difference to the resuscitation of trauma patients. What is clear, though, there is less research in pre-hospital care about these products than there is in hospital, and a lot of the evidence has been extrapolated, and we've been trying to help improve the evidence base in pre-hospital. But without going into details of all the papers, what we're tending to see is that whilst giving blood products in the pre-hospital environment, you might expect it to show a mortality improvement at discharge. It doesn't. And that's not really surprising when you consider the other interventions these patients have to undergo in order to survive. What is becoming clear is that some of the products we thought were traditionally used later in massive hemorrhage protocols, such as cryoprecipitate or fibrinogen or platelets, may perhaps be more useful if they're used earlier on in the patient's journey. And recent trials are more focused on this, such as Cryostat 2. So the other thing that's happened recently is fibrinogen, which Dan mentioned. Fibrinogen concentrate hasn't actually been licensed in the UK for use in traumatic hemorrhage until very recently, in fact, in October this year. So that now gives us another option to potentially consider for pre-hospital practice. Now, if you work in a major trauma centre, you'll be lucky to be part of a team. You'll have a massive hemorrhage protocol. When you have a trauma call for an exsanguinating patient, you'll have several physicians who are able to do multiple interventions at the same time. And you'll have nurses and therapists working around you to support you to provide timely care and try and shorten the time to definitive surgery for this group of patients. Now, whilst we strive for the same end in pre-hospital care, the chances are, even with an advanced pre-hospital team, that will consist usually of a single doctor and single paramedic, and perhaps with one additional team member being either a physician or paramedic. But actually, you're going to have to make some choices for your patient. Partly you're working in a different environment, and as the sort of slight fuzziness of this picture shows, it's often dark, it's often wet, and simple things like this just make the simplest tasks, such as opening a vial, a little bit more difficult. When you think about the processes that have to be undertaken to look after an exsanguinating patient, it might be difficult IV access requiring a central line. It could be an intervention such as Robura or a thoracotomy, and it could include an RSI or blood transfusion. And with the limited number of people of the team, you have to decide where your priorities lie. So trying to make all of these procedures as simple as possible, including blood transfusion, is a really important part of deciding what kit your team is going to carry. As Dan mentioned as well, when you decide to carry blood, whether you have a power source to keep blood products refrigerated is important, the weight of the kit, and also the resilience of your product, as in can you actually keep blood products cool and within the temperature range of 2 to 6 for the required time. So moving forward from 2008, we realised in 2008 there was a problem. And actually, this is the time we launched the Code Red protocol, which is fairly well known now. But originally, it was just started as an activation criteria for pre-hospital teams to let the hospital, it wasn't even an MTC then, but to let the Royal London Hospital know that we were bringing a patient in who we deemed would need blood products to make sure they were ready. So we started this in 2008 and it was quite effective, but increasingly we felt that the patients pre-hospitally should not just be resuscitated with saline. So we worked really hard with NHSBT and the transfusion lab at the Royal London to deliver packed red blood cells in Credo boxes, which would maintain the steady state temperature for 24 hours and allow us to carry 4 units on the helicopter and the cars. And what we found when we reviewed the data was that we had an overall reduction in transfusion requirements. We had no wastage because the blood was recirculated within the hospital, and the pre-hospital mortality was reduced from 34% down to 19%. The other benefit of this was that it allowed us to share our protocol with other air ambulances, and very rapidly the UK air ambulance teams responded. And now we're at the point today where 75% of the UK air ambulances have access to some type of blood product. However, there was a knock-on effect for the MTC. So as you can see, this graph this chart shows the incremental improvements in mortality within the Royal London Hospital after we implemented Code Red. Now, what you can see is from 2008 to 2012, we were doing quite well. The black bars represent deaths within the first 3 hours of admission, and the red bars of deaths within the first 24 hours. You can see when we added in pre-hospital red blood cells that actually the death rate in the hospital went up. And that's because we were effectively managing to resuscitate patients who previously would die out of hospital, and we were managing to get them into the emergency room and in some cases to the operating theatre. So that then becomes a challenge for the MTC for us to adapt our processes and pathways to ensure that we can then improve the care we're delivering and try and equate that to survival to discharge. The other important thing that happened during the evolution of this chart was in 2015, a very important study called the PROPER trial was published. And this was one of the seminal papers, which if you're not really up on transfusion literature, this would be a good one to read. But this looked at the importance of blood product ratios. And what it showed was that if you gave plasma, packed cells and platelets in a 1-to-1-to-1 ratio, your patients had a higher chance of survival. And this actually totally transformed UK transfusion guidance for trauma patients and also the European guidance. And now it's very clear, and I think every major trauma centre has a massive hemorrhage protocol which is geared towards delivering this high blood product ratio. So moving forward, that was 2015. And in 2016, we started thinking about how we might get plasma onto the aircraft and the cars. Now, plasma can be a little bit tricky. So lyophilized plasma is actually a bit of a pain to draw up and spin. Frozen plasma clearly isn't suitable for pre-hospital care, and thawed plasma back in 2015-16 only had a 24-hour shelf life, which meant it wasn't suitable for pre-hospital use and would result in high wastage. So we worked with NHSBT, and luckily in the Red Book, which is the Bible of transfusion medicine for the UK, there was a product which was used predominantly in neonatal medicine, which was a mix of red cells and plasma. Effectively, after blood donation of a whole unit of whole blood, UK practice says we have to leukodeplete the product to remove the white cells. When this is done, the filter that we've traditionally used in the UK almost accidentally removes platelets when it takes the white cells out, which means you're left with a product which is whole blood minus platelets, otherwise known as red cell and plasma. So we were successful in working with NHSBT to run a 2-year feasibility study looking at the use of red cell and plasma in the pre-hospital environment. We looked at logistics, clinical outcomes, and we also surveyed air ambulances and major trauma centres in the UK to see what products they were currently using and what they'd like to see used in future trials. Now, I'm sure you want to know what the clinical outcome of this was, and unfortunately that data is being analysed because the trial closed in October. But I'm hopeful it will show something similar to previous trials looking at early plasma and packed cells pre-hospitally, namely improvement in transfusion requirements, improvement in acid-base balance. I'm not sure it will equate to a mortality benefit, but it would be nice if it did. But what has been very clear is that there are other benefits to the clinical teams. So if you look at the other products that are currently carried by our ambulance teams, you can see that most of them have packed cells, and actually most of them have some form of plasma. And Lyoplas is quite popular, partly because it has a long shelf life and it's relatively easy to carry, although it's difficult to make up. As part of the study, we did a moulage, and we took 3 separate air ambulance teams who had 3 separate transfusion strategies, and we got them to moulage a patient that was shocked with non-compressible hemorrhage. And we measured the time it took them from decision to transfuse to get 2 units of packed cells and 2 units of plasma into the patient. And we made each team do it 3 times with the different strategies, and we calculated the average time they spent actually delivering hands-on time and the overall time it took to do the transfusion. And interestingly, it may not surprise you to know that if you just give 2 units of red cells and plasma, it's statistically significantly quicker than it is to do 2 units of packed cells and to make up 2 bottles of Lyoplas. But you can see the difference for the overall time was 6.5 minutes versus 16.5 minutes. So it's a lot of time, but actually when you consider the on-scene time for an air ambulance looking after an exsanguinating patient, this is clinically significant to the patient and to the team. When you also looked at the number of steps to do the more complicated transfusion, the pieces of equipment and the team involved, that also made the red cell and plasma a much more attractive option for the clinical team. So we asked the air ambulances and the MTCs what product would they ideally like to have for use in emergency for a trauma patient. So perhaps for the first hour in the MTC and for pre-hospital use. And as you can see from the survey, nearly everybody wanted a single component, i.e. whole blood or red cell and plasma. And a few places wanted different separate products, perhaps so they had more choice. But the key between the differences of whole blood and red cells and plasma is probably around where the platelets actually make a difference. Because if you remember, the whole blood would still have the platelet component in it, the red cell and plasma doesn't. What we do know about platelets now is that traditionally we thought platelets had to be stored at room temperature, and that's when they best functioned. But what we know now is that platelets at 4 degrees C are probably more active than they are at room temperature, although they stay in the circulation for a shorter time. But in trauma patients, that may not be a problem particularly. So it looks as though the UK would like to have whole blood as a possibility, and it is thought that the whole blood would be more beneficial than just the sum of the parts, perhaps because there's less additives in whole blood, there's been less processing, and certainly military and US papers have shown clinical and logistical benefit from delivering whole blood, and the US certainly have more practice. A lot of their clinic, Mayo Clinic, use it in day-to-day surgical practice as well as pre-hospital. Just moving on to TXA, and some people have already asked Mark some questions, but CRASH 2 and CRASH 3 are fairly popular trials. People have read them, and CRASH 2 is certainly embedded in ambulance service and air ambulance practice, and CRASH 3 is becoming so. One of the interesting questions that's come up recently, though, is can you give TXA IM? So Ian Roberts, the chief investigator for all of the crash trials, recently did a study looking at 30 trauma patients, 30 major trauma centre patients who'd already had the intravenous bolus dose. And what he found was that even in shocked patients, the absorption rate from IM injections was actually excellent and managed to reach therapeutic range in between 4 and 11 minutes and was maintained for between 5.6 and 10 hours. And obviously this could be really useful, partly for the military who could use it in auto injectors, but perhaps for mass casualty situations, or for ambulance service trusts where clinicians can't get IV access or have failed to do so. So this is, St Emlyn's have done a really good blog if anyone's interested in more information. The trial was called the Intact trial and was recently published in the British Journal of Anaesthesia. Someone also asked Mark about when would you give TXA in traumatic brain injury. So this is our Royal London protocol, which we actually brought in just after COVID. We waited until May to launch it, having made the decision in February because there was quite a lot going on. But we've decided to do a few things differently. We stopped giving the infusion dose of tranexamic acid about 2 years ago, based on some of our research data led by Karen Broey. So for code red patients, we were giving a 1 gram bolus pre-hospital and another 1 gram bolus in hospital. So we're now giving a total of 2 grams as a bolus, and we're not giving the 8-hour infusion unless ROTEM guided resuscitation recommends it. For the brain injury patients, what we call code black, we're giving it to the severely injured head injury patients as well, but we're also following the crash guidance to give it to patients with a GCS of less than 12, or patients with blood on their CT, or HEMS patients who are intubated because of a head injury. And again, they're getting a 2 gram bolus in total. Patients who are GCS 13 or 14, we're fast tracking to CT. Now, the pre-hospital air ambulance team are giving the 2 gram bolus for bleeding patients, but the ambulance service and HEMS are giving a 1 gram bolus pre-hospital for the brain injuries, and that's being topped up in the MTC. So just finally, talked a bit about the blood products that we're trying to give pre-hospital, and clearly there's a move towards us wanting to try whole blood, and we're hoping that with a national group, we're currently trying to get funding to do a trial involving several air ambulances in different locations, not just urban but rural services, and look at what potentially the outcome would be from that. But if you want to read a bit more about not just the blood products, but how as an MTC, the Royal London has addressed the code red protocols and the management of exsanguinating patients, we published this paper last year, which is really a story of marginal gains and collaboration between research teams, charities supporting innovation, and the clinical teams, both pre-hospital and in the MTC. And hopefully that would give you some more detail than we've been able to cover just this evening. I think the key message, though, is that it's quite an exciting time for blood products in pre-hospital care. There's a real appetite to try and find the right solution. There's no doubt that the patients deserve to have access to the same components that they would in the MTC, and the challenge is for us to try and work out how we can safely take those products out of the hospital environment without invoking additional wastage, but ensuring clinical and cost effectiveness. Thank you.
Thank you. You've managed to fit an amazing amount into a short time. We're running out of time now, so I'm just going to ask you one question. There are some questions online which would be which you can type an answer to in a second. But has the COVID pandemic changed the demand and supply of blood for trauma patients in the UK?
Yes, I mean, I think it's been interesting because whilst most MTCs, I think, saw an initial drop during the lockdown 1, we then saw an increase in severity of the patients. And actually, from an air ambulance point of view, we saw more patients who required a blood transfusion between March and May this year than we did in the year before. So the need for blood products absolutely hasn't gone away. NHSBT put in contingencies which they haven't had to use, but included reducing the dose of platelets in a pool, extending the shelf life of red blood cells from 35 to 40 days, and also promoting the use of plasma first in some cases if O-negative red cells were in short supply. But I think the key message for anyone, there's quite a lot of people on this call, but if you are a blood donor and you haven't already donated during COVID, I think it'd be massively appreciated if people can get back to that as part of their normal schedule.
Okay, That's brilliant. Thank you. Just to finish this, I can't help but put in a plug for pre-hospital emergency medicine. The concept of pre-hospital emergency medicine as a subspecialty is uncommon, certainly in Europe, and it's something which is relatively new. With your experience and involvement in pre-hospital care, what would you say to doctors considering pre-hospital care as a career option? Should we ask all of you? Mark, do you want to answer that one? Don't do it.
So say again, David, so I didn't quite catch all that. A career emergency.
Yeah, what would you say to someone setting out and thinking about doing pre-hospital emergency medicine as a career?
Well, I think I've always viewed emergency medicine as emergency pre-hospital emergency, the field of pre-hospital emergency care, as being multiple fields, as in like it's a bit like the ultimate is or general practice. It's pulling everything in together. So whilst emergency medicine is without a shadow of a doubt the one that covers most of it, you need to get as much experience as you can in all the other fields as you can. So I'm a neurosurgeon mostly now, but pre-hospital care world is the closest you get, I think, to being a real proper doctor who does a bit of everything. It's what I enjoy.
Excellent. Dan, what have you got to say about that?
Look, Australia has recently developed the Diploma in Pre-Hospital and Retrieval Medicine, which has going live this year, next year, slightly delayed due to COVID. But and we now have a faculty of Pre-Hospital and Retrieval Medicine, a joint faculty together with the intensivists and the rural and remote GPs and the anaesthetists. But it's hosted by the College of Emergency Medicine. And now we're accrediting sites in Australia for pre-hospital retrieval medicine so that you can go there to train in order to prepare for the diploma. Look, it's taken off. It's so the laws of economics apply, supply and demand. People want it, and this is what we've got here now. I would say now is as good a time as any, and in fact, you could consider yourself to be a bit of a pioneer if you get stuck in now, because I think it's going to go from strength to strength.
Brilliant. Anne?
I'm really sorry, I sort of forgotten the question. I was trying to answer some of the questions.
Sorry, what would you say to people who are thinking about setting off on a career in pre-hospital emergency medicine?
I think, yeah, absolutely do it. I think certainly for emergency physicians, emergency medicine is getting quite tough to do full time. And I think it allows you to really keep some core skills like intubation, arterial access, some things which are done by anaesthetists traditionally in the hospital. But I think it gives you time to be outside, working with a different team, keep your clinical skills up, keep your clinical acumen up. I think there's so many pluses to doing that role, and you get to work with different groups of people. So I think, yeah, you should definitely do it. The challenge is to get experience before you do a formal job. But we're just a little plug, we're going to put some stuff on the Royal College of Emergency Medicine website, which is going to give people ideas of opportunities to try and get experience at all levels.
Brilliant. We're being told we've run out of time. It's been fun and informative to hear from three experts who are not only experts, but also friends. Thank you again to Mike Griffin, who was on the call earlier, the president of the college, for inviting us this evening. And I hope you've enjoyed hearing from the Faculty of Pre-Hospital Care. Thank you very much to the panelists and to the participants. And good night.
Thanks.